Hey everybody, Mark Dawes here, and in this short video I want to address an article that appeared in the Guardian newspaper on the 10th of December 2017, and the article is entitled Alarm over Restraint of NHS Mental Health Patients. And this article revealed that there were 80,000 restraints of patients on mental health units in the UK last year. That's between 2016 and 2017. This included 10,000 who were held face down or given injections to subdue them. Girls and young women under the age of 20 were the most likely to be restrained, each one being physically restrained an average of 30 times a year. And black people were 3 times more likely to be restrained than white people. Patients who were controlled by non-prone physical restraint had that done to them 43,000 times, and that chemical restraint was used on another 8,600 occasions. And the figures were published by the NHS Digital Statistical Agency. The Guardian newspaper also reported that in its annual report in July, the Care Quality Commission, which regulates NHS care in England, said its inspectors had found unwarranted and wide-ranging variation between units in terms of how often staff use restraint. Wards with low rates had staff who had been trained to handle difficult behaviour and de-escalate challenging situations. And I'll come on to that in a minute when I give you my opinion about conflict management training. The Department of Health, who issued guidance in 2014, said that restraints should only be used as a last resort, and if other means of dealing with difficult situations were unlikely to succeed. And a spokeswoman for the Department of Health said that physical restraint should only be used as a last resort and that anything else is unacceptable. So my question is, despite all the guidance to the contrary, why are so many restraints taking place, and why are techniques such as face down and prone still being used to the degree that they are? And I'd like to make one other thing clear right from the start. The vast majority of staff that I meet who work in mental health units genuinely care for the patients that they look after. They are absolutely committed to keeping their patients safe. And I know of a number of people who chose to work in mental health for personal reasons. Some because they had a close relative or a friend die due to a mental health illness, and others because they have a close relative or friend suffering from a mental health illness. Therefore, I'd like you to be mindful that when we read statistics like this, we don't jump to the presumption that staff who work in mental health units get some sort of perverse pleasure out of restraining people who are mentally ill. In the vast majority of cases, that is far from the truth. These staff genuinely and passionately care for the people that they look after. Now, let me explain this a little bit further for you. In a recent conversation I had with a very, very experienced mental health professional who is also a restraint trainer, or as they call them in some areas of the NHS, a PMVA trainer, we had a discussion about staffing levels and the issues that he's experiencing on his wards. And he said the problem they have right now is that there are a lot of staff who are working up to a later retirement age, because obviously the retirement age now has gone up for people working in the NHS. But there's also the issue of a lot more younger people coming in who are suffering with mental health issues. Therefore, you have staff who are older, not as fit, who may be suffering injuries, trying to physically care for and in some cases control younger and much fitter and stronger patients who are exhibiting challenging and violent and aggressive behaviour. And they're finding it difficult. But this is also compounded by other issues, and let me just explain them to you, one by one. And it's not an exhaustive list, by the way. It's just some things that I've picked up on, having been doing this for a long time. Okay, guidance. Well, there's a lot of well-meaning guidance out there, and it's produced by very well-meaning people, and I get what they're trying to do. They're trying to stop the overuse of restraint, particularly some techniques and positions that may increase the risk of death. And I get that, and I absolutely get it. However, a lot of this advice and guidance is published is contradictory. One piece of legislation or one piece of guidance contradicts the other, and in fact, in one piece of guidance, it actually contradicts itself. Now, the problem managers have with this in the NHS is when the CQC inspectors come along to actually, check against the guidance, the managers don't know what they should and shouldn't be doing, so they will just go with a CQC inspector's recommendations for fear of being sanctioned. So they don't want to upset a CQC inspector. So whether they think the CQC inspector is right or wrong never becomes the issue. The fact is they just agree with it because they don't want to be sanctioned. That, in many cases, it compromises patient safety and care, as well as staff safety as well. Now, A lot of people will follow this guidance, Department of Health guidance, and I'm referring to the Positive and Proactive Care guidance issued on the 1st of April 2014, by the way, and I'll leave a link below the video to it. Because they've actually been told, or they believe, that the actual guidance is legally enforceable. Well, it's not. The actual document is not statutory guidance. And in fact, the NHS Protect, which is now obviously a defunct organisation, but NHS Protect back in March 2015, issued a document, a clarification document, and in that document it states this, and it says, the Positive and Proactive Care guidance provides information and good practice. It is not statutory guidance or legally binding. So that means we can depart from the guidance if we need to, provided we have cogent reasons, and I'll come on to that in a little bit later on. Now, there's another aspect to this too, and that is that some training organisations out there are still teaching outdated and old types of systems and are still using techniques which have been advised, even by coroners, not to be used, such as face-down restraint, prone restraint, and other techniques that increase the risk of harm and death. And they do this despite the fact that alternatives, or indeed safer alternatives, exist. Now, one of the reasons they do this is because when they develop their systems, they're fundamentally set in stone. That means they can't change. And that they don't evolve with time, so they never seem to move on. And I think this is primarily down to a cognitive bias. And the cognitive bias I'm referring to specifically is what's referred to as the IKEA effect. Now, Daniel Kahneman won the Nobel Prize for research onto this. And in terms of the IKEA effect, what that means is I made it, so it must be right. So in other words, there's an ownership and there's a protectiveness to something that we produce. And even if we produce it wrong, we still defend it as though it's right, despite evidence to the fact that it's wrong. And that's a very, very strong point and something that people need to consider when they're looking at commissioning training programs. And a lot of these training companies promote their services as though they're accredited and approved. Well, actually, in many cases, they're only self-accredited and they're only self-approved, or they're accredited by an agency that only has a self-accreditation basis without any basis in relation to a national vocational qualification or an independent audit or independent review. And for clarity, by the way, the Department of Health, and indeed no other government department or agency, actually approves or accredits anything. They will not do it. They do not approve or accredit any system of restraint, despite the fact that some agencies actually try and promote their system on that basis. Now, you may see, for example, that a government document, a Department of Health document, may say an example of accreditation will be. Well, we've challenged the government on this because we said you cannot promote one system over another. We've got letters from the Minister of Health, etc. on this one. And what they say is we're not trying to promote one over the other. We're not favouring one. We are merely signposting people. But here's the thing, I'll be absolutely straight with you. They're signposting people towards organisations that provide a self-accredited system of accreditation, not a formal one recognised by a national vocational standard or a regulated awarding organisation, which is, again, regulated by Ofqual. So that makes it interesting as well. Now, many NHS management systems and managers out there will not actually look at equipment which could provide alternatives to prone and face-down restraint. And there's good equipment out there. The safety pod, the soft restraint belt, the soft restraint kit. These are brilliant pieces of equipment, and they could reduce or eliminate the need to restrain people in a prone or face-down position. They've been medically reviewed, they've been industry tested, and they're absolutely fit for purpose. But again, managers are reluctant to actually buy this equipment for various reasons, and the one I hear time and time again is we have no budget. And the other one I hear, which is quite common, is, well, we don't want to be using equipment to restrain people, it's not ethical. Actually, not using the equipment to restrain someone isn't ethical if the equipment is the least intrusive option. And I'll come on to that probably in a later video. Now, in many organisations, there's also a high dependency now on agency staff, so part-time staff that are recruited from agencies to supplement the employed staff on wards and units. And the problem we have here is a two-tier approach to actually managing the use of force in an organisation. So employed staff will be trained within the system that organisation wishes them to use. Then agency staff will come along who may be trained in that system, they may be trained in another system, or they may not be trained in any system whatsoever. And this causes an immense amount of confusion, is terribly difficult to manage, and increases risk. Well, you heard me mention just now about conflict management and de-escalation training, and you heard me mention the fact that CQC are quite keen on it because they allegedly have evidence to support that where conflict management and de-escalation is being implemented, there are lesser incidents of restraint. Well, I can tell you now that in many areas, conflict management training is not being implemented, and this is primarily because the organisation cannot allocate the additional time to allow staff to be released from the wards for conflict management training because they're needed on the wards because of staffing issues. And here's my biggest gripe. Some of these so-called panels that are set up by government departments to actually look at developing and designing this guidance that they bring out are made up in the main by people who've never actually physically had to control someone in reality, or have done it that long ago they can't even remember what it's like, or they've been bludgeoned on the head by a government directive that says make this happen this way, and therefore take no notice of any specific expert they may have on that panel. And that's my biggest gripe. And we've had this with the government panel, and we challenged it, and when we challenged it, a particular comment by the chair of that panel, we had it proved by an independent lawyer that the comment made by the chair of the panel that she was trying to bully, basically, and steamroll through was legally flawed. It had no basis in law. And number two on that panel, who had the OBE as well, by the way, also was giving out legally flawed advice. But that's the problem. We have these panels that look at actually placating government and producing guides, but it has no basis in law, and then this gets pushed through. Okay, so I've had a bit of a rant, but what's the actual point I'm making? Well, the point I'm making is this. Any restraint system must be fit for purpose. I mean, I think that goes without saying, that's pretty obvious. But it must be fit for purpose for the environment it's going to be used in and for the makeup of the staff and service user or patient demographic. And it must actually have a basis in the law. It can't just have a basis in opinion. Restraint systems must also be underpinned by current evidence and research in this area into what works and what doesn't, and not just be down to an individual's or a committee's opinion as to what they think they should and shouldn't do, because that actually leads to another problem, which is classified in a system called HSG 48 as a rule-based or a knowledge-based mistake. And it's been evidenced time and time again that where these opinions are allowed to override fact and evidence, mainly because of the IKEA effect, a cognitive bias, we have an increased margin for human error, and the problem is the system fails because it wasn't fit for purpose, the member of staff is hung out to dry, but the system was designed with failure built in because it's not being allowed to continually develop and evolve in line with current evidence and research, and of course feedback from operational incidents in the place of work. And what this means then is that if an organisation needs to detract from the Department of Health guidance, the positive and proactive care guidance, which actually is not statutory guidance anyway, if it's done all the work and it has all the evidence and it has everything to support it, it can do so because it can justify that it has what's now termed as cogent reasons for doing so. And that is defensible against any challenge by an inspector, and it is certainly defensible or good defensive evidence if you are challenged in court. In short, the days of implementing training simply by commissioning and off-the-shelf training package are gone. And this was highlighted by Lady Nuala Alone, who was commissioned by a previous government to investigate complaints of mistreatment of deportees post the death of Jimmy Mabenga, who died on a flight, being restrained on a flight out of Heathrow in 2010. And when interviewed by the Guardian newspaper on the death of Jimmy Mabenga, Lady Nuala Alone stated that the training, and this was the training that the staff had received, was textbook training, but it was one size fits all. It made no difference whether they were dealing with a 5-foot girl or a 20-stone man. Therefore, it isn't about what system of restraint you use per se, or which training provider you choose to commission for you to deliver the training for your organisation. What it is about is ensuring that whatever you start has the capability to be able to adapt and change, and has the flexibility to evolve over time to meet the needs of the organisation, the staff and the service user, ever-changing demographic these days. And that is true accreditation. That will stand the test of time. That will give you a legally defensible training system. So the point I'm making to you is this: if you are a commissioning agency, an NHS trust or hospital, stop looking for the holy grail of restraint training in a training provider. It doesn't exist, okay? The holy grail, the panacea, or the way forward with this is to accept that what you start with must change over time, and you need to work in partnership with your training provider. You need to make sure that your training provider is up to date on current knowledge and expertise, and not just accept it because they say we have a badge or we're accredited by. And that includes us, by the way. Check everyone out fully. And that's the only true accreditation you need. Now, if you'd like to know more about this, or how we can help you, or indeed how we help one organisation reduce the need to restrain people in a prone or face down position, then get in touch and we'd be delighted to help you too. In the meantime, please feel free to share this video. Please leave a comment. I'll be interested on your thoughts on this one. There's probably a comments box below. And share the video, share the love, subscribe to our YouTube channel. Thanks for watching, and I'll speak to you soon.